something which is useful and new and some very takes challenge, you know.
Yeah, yeah. Both the wife and husband both are very aggressive and active in wherever the opportunity is there.
Yes, correct, correct. They utilize opportunity in a proper way.
Very sharp.
Yeah, it's very sharp. I have seen him since he was sitting in the what we call is the polyclinic.
Yeah, yeah. PG, and I know him since PG days.
Okay, 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 okay. Yeah, yeah, yeah. But he's very hardworking and still is updated in his subject.
Yeah, yeah. Very well.
Yeah,
Very
it's,
shrewd.
for example, one of the now the latest we take more interest in dermatophytosis.
Yeah.
He is the only dermatologist who has done 1800 culture because he has
Correct.
a culture facility in his own hospital.
My God.
Yeah, so he's a different kind of person. He goes all out. At least I do not know any dermatologist has got his own culture facilities. There are mycologists they are doing, but not dermatologists.
Correct.
Yes.
I think Satish Pai was having earlier.
Oh, then I am not.
Dr. Satish Pai was having the
Oh,
same.
he was doing that. I was not aware of that. Huh?
But after he has stopped.
Okay, okay. Yeah, because hardly it is useful, but he's doing for academic purpose
Correct.
more than the clinical. Yeah.
Sorry, sir, I lost my net while I was interacting with you.
Okay, okay. Yeah, that's why
Right,
Lakshman
sir.
was keeping me busy. Yeah,
So in
The
dermatophytosis,
people were more worried when we had 100 patients. Then we are approaching 1 lakh. People are now things are getting in a way normalized. Lot of asymptomatic patients around.
yes, correct, correct. No, as you said, Amit ji, initially we were confused. The
Right,
politicians, stakeholders, all doctors, we were not knowing what to do.
right,
I
right, right,
think
right.
now we have come to some decision where we can now avoid asymptomatic patients.
Correct, correct, correct,
Mild
correct.
symptoms we are observing at home,
Right, right,
and
right, right.
moderate we are sure that we can treat them.
Right, 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 right.
And now there is not a single word about ventilator is not available. Have you heard in last 2 weeks?
No, no, absolutely not. That is true, sir. Very true.
Yeah.
In fact, now people are also clear with the city levels that below 24 is a spreader and above 24 is not
Yeah.
a spreader.
Yeah. 1 second, huh, please. 1 second.
Yes, sir.
Hello. Sorry.
Yes,
Yeah.
sir.
So the doctors have also become confident with the availability of flupiravir plus remdesivir. We have become, means doctors have become more confident, you know.
Right, sir. Right, sir.
Yeah, and availability is also not a problem. Now tocilizumab is not available, but itolizumab is available. So something or other is available.
Right, sir. Right, sir. Right, sir. Right, sir. So I think Deepak, shall we start?
yes,
But Cadila has flupiravir or no?
No, no, sir.
no, sir.
We have a product, Sapsivac, which is our product which will build innate immunity, and that's being used in multiple centers.
Okay, okay, good, very good.
That is a
So,
heat-killed Mycobacterium W vaccine that we have.
uh-huh.
So it was being used for sepsis, but getting repurposed for COVID usage, and multiple centers it is approved, right, Dr. Pratik?
Oh, is useful in
Yes, yes.
septicemia also or only
No, so,
chronic?
sir, the first approval came recently, means the recent approval was in sepsis, moderate to severe sepsis.
Okay, okay, okay.
And based on that only, the investigators from PGI got interested to explore it in the other, because the cytokine storm we have in sepsis, same we have in severe COVID-19 as well.
Yes, correct. Yeah.
So PGI and the 3 AIM center have where they started the trial.
Okay.
And we in fact recently
PGI
submitted.
where? PGI Chandigarh or?
Yes, sir. PGI
PGI
Chandigarh,
Chandigarh.
AIMS Delhi, AIMS Bhopal, and AIMS Odisha.
Oh, that's
Bhubaneswar.
very good. Now a lot of, at least the COVID has started a lot of research in our country.
Correct.
Yeah, there are a lot of silver lining of COVIDs.
Right, sir. Sir,
Yeah.
good evening and welcome. Let me welcome all the audience who have come for this August CME Academia 2020 as a part of our digital CME series, wherein we'll have a discussion on psoriasis and biologicals. While most of the companies are shying away from introducing newer products, Cadila has taken a step forward during this time. We have launched 4 biosimilars. In the area of oncology, in the area of osteoporosis, or autoimmune disorders, like in psoriasis, we are introducing. And we thought that it is still the right time that biologicals can get picked up. So biologicals or any such product, also with respect to pricing, when the pricing becomes right, usage increases, and we realize that with Cadila playing an active role in helping reduce the price, usage will go up. And for that to happen, I think there has to be a good understanding, and that's why this Academia 2020, where we have this topic of psoriasis and biologicals. So I welcome everyone for this topic, and I'm especially thankful for Dr. Saple for becoming the speaker for today's program. Can we go to the next slide? Deepak, next slide. Well, sir, I'm Amit Ajmera, Vice President and Head Vertical 3, which is our ortho, rheumatology and derma business. And on behalf of the entire company, this is our beautiful campus at Ahmedabad. All of you are most welcome. And on behalf of the entire team, I welcome you for this CME. Of course, the tourism has completely stopped. So whenever the tourism restarts, I think we would like to see you in our campus here with a very beautiful conference room as well, where we can do a lot of advisory and other meetings as well. Can we go ahead? With this, I think without taking much time, I'll straight away hand it over to Dr. Pratik Patel, our medical advisor, to introduce the speaker for the day and take this program forward. Welcome once again, sir, for this CM. And thank you very much for becoming a speaker.
Sure. Thank you so much, Mr. Ajmera. So, sir, today's CM is special for us in terms of educational activities because we are celebrating Teachers' Day tomorrow. So, we wanted to have a speaker who has been a teacher, and you have been an experienced teacher. Your entire and it is this CM is dedicated to all those teachers, especially in the medical fraternity, who have inspired the bright young minds to take the profession. And honestly, sir, thank you so much. I can means nothing to introduce you because everybody knows you, considering your vast research experience in the not only the field of dermatology, but also your dedication to the field of HIV and AIDS in India. Sir has been a consultant in Dermato-venereology and HIV/AIDS, and sir has served at the Breach Candy Hospital and SL Raheja Hospital. Sir has been an ex-president of IADVL Maharashtra branch and ex-president of CPS Mumbai, examiner for MD students at various universities. Has delivered more than 1,000 lectures across both national and international conferences, different venues so far. And sir has been involved in international collaboration in academic research with Harvard School of Public Health, John Hopkins University, University of Yale, University of Toyama and Osaka. Sir has received a lifetime achievement from our National Medical Association, that is IMA, in 2017. Not only that, sir also received a lifetime achievement award by our National Dermatology Association, that is Indian Association of Dermatology, Venereology and Leprologists in 2018. Also, sir received recently Best Practitioner Award at DermaCon International Congress held at Bangalore 2019, and honored as a mentor for IADVL Fellowship in Derma 2020. Sir has been involved in a special active research area in the interest of specifically to clinical dermatology, including dermatophytosis and psoriasis as well. So we welcome you, sir, once again, and over to you, sir.
I think, shall I start sharing my slides?
Yes, sir. Yes, please.
Yeah, doctor, I'm just stop sharing it so that you can share your slide, Dr. Saple.
Yeah. Okay.
Yeah, and once again, a very warm welcome, doctor.
Okay. Thank
Yeah.
you. You cannot start screen share. Okay.
There is a
Sir, it works. It works one at a time. So since we were doing it, you were not able to do. Now you can do it, sir.
Okay. Yeah, it's okay.
yes.
Yeah, yeah.
Yes, sir. You can enlarge the screen and you can start
Yeah, I'll do that. Hmm. Slideshow. Yeah,
from beginning.
from beginning. Okay. Now I'll go for the pointer. Okay, I'm ready now. It is okay.
Yes, sir. Perfect.
Yeah, it's okay. Thank you, Cadila Academia 2020 and Vice President Amit Ajmera and Pratik Lakshminarayan and the whole team for giving me this opportunity to share whatever my experience about the management of psoriasis and use of biologicals. So when you're talking about psoriasis, all of us we know psoriasis is a very common condition in our clinical practice, and all of us also we know is a chronic conditions, and it was known up to now that, or many of dermatologists, they were thinking it's confined to the skin, but it is proved beyond doubt. Now it has not remained the skin condition, but it has got involvement of the internal organ or inflammation of the internal organs. So it has become a systemic disease, is well accepted. When we are talking about psoriasis, almost 2% of the world population, of course, on an average is affected of psoriasis. Males, females are all equal. When they affected, usually the early onset is severe and the late onset is usually mild. But if you see the life expectancy in the male and female, they die early compared to the patient without psoriasis. So definitely has got morbidity and mortality because of the underlying psoriasis. That is because of the systemic involvement. So before going for a psoriasis information, we should know what is the burden of psoriasis. If you see 125 million people, in fact, they say every third person has been affected in the world of psoriasis, usually that either of moderate or severe. That's why the information, not only the large number of people affected, but if you see 70% of the patient, they get psoriasis the age, what is called the age of productivity. So usually at the age of 40, so productivity is affected. Then not only productivity, but it has got impact on social life. When it has got impact of the individual life and the social life, when I talk about the individual life, almost 80% of the people, they are facing problem every day. 50% of the patient, they have problem with the sleep. 35% they have problem using their hands, because many times when they're working, the hand becomes problem. 29% they got problem with the sexual activity, and 31% they got problem all the time. So they have more social problem. Along with social problem, of course, I said about the workload. If you see, 60% of the patient, they miss their 26 days of work because of underlying psoriasis. So it has got physical, mental, and social impact on the quality of life. So in comorbidity, when you're talking of the comorbidity, stigmatization and lack of self-esteem, that's very important. Either they go into depression, suicidal ideation, anxiety, or sexual dysfunction. Then talking about the comorbidity, psoriasis is not remain confined to the skin, but it has got systemic comorbidity like involvement of the eye, involvement of the GI tract, that is a Crohn disease, liver disease, psoriatic arthritis, nail, dyslipidemia, insulin resistant diabetes, obesity, high cardiovascular risk. Now, there are many more comorbidities. So even if you look here, liver is also involved, depression is there, inflammation is there. So we are living, for example, if you look at these slides, there is micro-inflammation, insulin resistance and obesity, myocardial infarction, atherosclerosis, stroke, metabolic syndrome, anxiety disorder, depression. You just mention in everything, you get it. And of course, because of that, they get hooked on smoking or alcohol, they become obese, and of course, it affects their lifestyle. So when it has got so much social impact in the quality of life, and almost 125 million people are affected all over the world, we've got to know what is its etiology. When you are talking about the etiology, still we are not sure, but one of the etiology nowadays considered is a autoimmune disease. And even it is autoimmune disease, still we do not know what is the exact antigen which is responsible for production of antibodies. But there are other factors like hereditary or a family predisposition, immune factor, environmental factors. But it is considered as an autoimmune disease where we do not know what is exact antigen or stimulating factors. But we are aware of that there are certain triggering factor or aggravating factor like a trauma, underlying infection like HIV infection, hypocalcemia, psychological traits, certain drugs like lithium antipsychotic, beta blocker, anti-malarial, interferon, NSAID, these are all aggravating factors. And of course, smoking and alcohol consumption. So these are the various aggravating factors. Now we know what is the etiology, but we got to know what is the pathogenesis. In pathogenesis, of course, clinically what you see is a plaque with erythema and scaling and inflammation. But if you go for the skin pathology, in skin pathology, you'll see elongation of the rete ridges, there is a hyperkeratosis, proliferation of the cell, and dilatation of what is called a suprapapillary veins. So these are the changes we get. We used to now depend upon the, first is a clinical, after that we started doing biopsy. Then we started doing what is called cytohistochemistry. Cytohistochemistry came to know there is a cellular infiltrate to the CD3 cell, CD8 cell, and dendritic cell, that is CD8 cell. So cytohistochemistry has given more insight that we are dealing with the immunology. Then we are going to deeper. Only the cells is not enough. So what is happening intracellularly? Of course, this is very complicated things, but it's very simple in the presence of external stimuli and predisposing factors. The dendritic cell, that is CD8, they get activated, what they call is the APC, antigen presenting cells, who are present on skin. This APC, the antigen presenting cell, they take antigens to the lymph nodes, draining lymph nodes, where the lymph nodes, the naive cells, they start activating, and there are two types of cells are producing what is called cytotoxic cell, T lymphocyte cytotoxic and T helper cell. The T helper cells are usually useful for the what is a clonalization of our CD4 for signaling, while cytotoxic cells are responsible for the cytotoxics. And these cells, they produce cytokines, and these cytokines, that is in interleukin 23, interleukin 17, interleukin 12, all these are responsible for inflammation. So psoriasis. So this is how the pathogenesis is there. But then I am being an HIV clinician. Many times we see patients in HIV with psoriasis. But psoriasis, if you see immunologically, usually there, if you see their interleukin is, of course, in psoriasis, interleukin is 12 and 23 and 17, while in psoriasis, IL-4, IL-5, 10. And In psoriasis, CD cells are increased, while in HIV, CD decrease. So why this has happened? Because it is quite paradoxical compared to psoriasis. But they say probably this happened because depletion of CD4 suppressor, or because what you call is a super antigen. HIV acts as super antigen. That's why in psoriasis, when HIV patient come with a psoriasis, we have to find out psoriasis related to HIV or not HIV. Usually related to HIV, they will respond to antiretroviral treatment more than psoriatic treatment. Then now coming to diagnosis. Diagnosis psoriasis clinically is not difficult, but there are certain differential diagnoses we have to keep in mind. Before that, we should know the psoriasis vulgaris, that is a common psoriasis, almost account to 90% of the all cases. 20% usually their involvement of the nail is there, sometimes 24%, and 90% of the with the psoriatic arthritis, the skin manifestation precede arthritis. That's why any patient of psoriasis come to our clinic, we have to keep in mind, or we should always look for the arthritis, psoriatic arthritis, that should be there. So what are the type of psoriasis we deal with? We know it, but I'm just repeating: plaque psoriasis, scalp psoriasis, nail psoriasis, gutted psoriasis, and erythrodermic is 2%, is not that, and pustular psoriasis is quite rare, but inverse psoriasis sometimes you can get more than 10%. So inverse psoriasis is very important because the differential diagnosis. So these are the various psoriasis presentation. So now coming to the important part of psoriasis, that is the differential diagnosis. Depends upon localized lesion, flexural lesions, gutted lesions, or erythematous or palmoplantar. So we'll go one by one. Like in today's recalcitrant dermatophytosis, we know that one of the important cause is application of steroid. When they come with the application of steroid, they come with what we call is an atypical presentation. When they come in, a tinea incognito can be mistaken for psoriasis. Of course, one of the differential diagnoses is central clearing, but tinea incognito, you may not get central clearing. That's why I keep on telling each and every dermatologist, which I'm practicing from the beginning of my practice, that KOH preparation you can do very easily in your clinic, and that will give a diagnosis. So I'll suggest keep one microscope. Microscope is not that expensive. It costs 5 to 10,000. We don't require that high magnified microscope. And that will help you. And you train one of your reception or somebody how to take scraping, and he can take a scraping, put it, and you can see under the microscope. So one of my suggestion, if you are doubtful is a tinea psoriasis, always take help of KOH preparation. Yeah, otherwise go for the central clearing. Second differential diagnosis with a plaque psoriasis is atopic dermatitis, or what you call discoid eczema. Usually if you see in the discoid eczema, scales are not silvery, but itching is more compared to, if you look for the psoriasis, there will be more erythema, more scales and silvery scales, and comparatively itching is less. Third condition is called bovine disease. Bovine disease is not that common in our country, but can be mistaken. I remember one of the patient came to my clinic. He was treated for plaque psoriasis for 4 years. But when he came, see, there is an atrophy. You'll get an atrophy center. Scales cannot come out easily. Like psoriasis scales come out very easily. Any patient of psoriasis sits on your examination bed, he comes out, you'll find the bed is full of the scales, fine scale. So scale, that will give you an idea, and where the biopsy is a must to rule out the bovine disease. Another common differential diagnosis is seborrheic dermatitis. Usually seborrheic dermatitis, the lesions are diffuse, while in psoriasis, you'll get line of demarcation. This is very simple, and still you are doubtful, of course the history will help you, the family history will help you, but in both you get a family history. But in seborrheic dermatitis, many times you will get a history of patient is associated with atopic dermatitis in the family. Still you are doubtful, I'll suggest biopsy. Then another differential diagnosis is cutaneous cell lymphoma. Of course, it's not common again in in our country, but I'll tell you, one of the patient who was diagnosed as a lepra reaction. He came to my clinic, was taking treatment for 2-3 years. The lesions were increasing. They become tumor-like or nodular-like. It was initially plaque-like things, but treated for the leprosy. So any patient comes, the history is very important. In fact, dermatologists, they are in a hurry because they have seen large number of patients. But I'm not just boasting. You come to my clinic, any patient comes to the clinic, we spend more time of the history. In the history, how long is there, what type of treatment is done, what type of investigations are done, is there any comorbidity, patient is on any drug therapy, whatever it is, all information we take it like any other clinician take it, which is very necessary. That history will give you idea. And then you can, so again here, biopsy is a must to rule out lymphoma. Then coming to a differential diagnosis of gutted psoriasis. The close differential gutted psoriasis, pityriasis rosea. Pityriasis rosea, of course, is very easy to diagnose because what we call is a mother patch, a Christmas tree-like pattern, but sometimes the scaly or the chronic pityriasis, sometimes pityriasis rosea also can last for 6 months to 18 months. Chronic pityriasis rosea or pityriasis rosea Vidal type. I have seen those cases. So sometimes very difficult. There again, I'll suggest biopsy. Then coming to psoriasis, syphilis. Nowadays, syphilis is not seen much. But in 93, 94, we used to see almost, because the era of HIV, almost one patient of secondary syphilis every day. It was that common. So how to differentiate secondary syphilis from the gutted psoriasis? Usually secondary syphilis, of course, the history will be there, but in gutted psoriasis, history of recurrent attack will be there. Syphilis, there won't be any recurrence. You won't get history of he had about 3 months back, 2 months back, and it is recurrent. That is the first. Secondly, of course, lymphadenopathy in secondary syphilis, you get it unless until it is say psoriatic erythroderma, you don't get lymphadenopathy. Genitalia look for mucous membrane, and of course, then you go for the test and biopsy also. Coming to another differential diagnosis is many times patient comes with what we call intertrigo. But intertrigo is a morphological diagnosis, and that is the most difficult dermatological problem I'm dealing. Last 4 years, I keep on discussing with my associate. We are almost 8 doctors who are working in my clinic. How to find out clinically, how to suspect, is it because of tinea, is it because of candida, is it because of psoriasis, is it because of atopy, is it because of irritant dermatitis, or is any other disease, like a rare disease like a Haley disease, but rare, but we have to sometimes skip in the, sometimes there is a mixed infection. It looks very easy, but in the recalcitrant dermatophytosis, you may get tinea infection also like that. So it's very difficult to differentiate. I'll give one of the examples. See, this patient came to my clinic. He was being treated by dermatologist for 2 years. When he used to apply steroid, he used to feel better. He used to take some tablet, antihistaminic, antibiotic, systemic steroid, he used to feel better. Then he used to stop like that. He used to go from one doctor to another doctor. This is another magnified view. When he comes to, so any patient comes to your clinic, and if there is a history of taking medicine for more than 6 months, 1 year, without much relief, you must try to find out what is the cause. And of course here, the first investigation you do KOH. In KOH you do not find fungus, Then you go for the next, that is we went for the biopsy. And see biopsy, what you find is a psoriasis. So psoriasis is one of the differential. The patient is having chronic intertrigo. Keep in mind atopic dermatitis or even psoriasis. These are the things are look very simple but are very difficult to deal in our clinical practice. That is at least my experience. I'm finding very difficult to treat them. Then coming to tinea cruris, then coming the children. Children is atopic dermatitis, again is very difficult, whether it's atopic dermatitis, whether it's psoriasis or is tinea. So their history is very important in atopic dermatitis. Then another differential diagnosis, candidiasis. Of course, candidiasis, we see pustules, small group of the pustules at the periphery, but sometimes is difficult. Then coming to palmoplantar hyperkeratosis. When you think of palmoplantar hyperkeratosis, you have to differentiate for tinea manum or tinea of the palm. Usually in tinea, you get asymmetrical. One hand is affected. I do not know, but usually that is the picture. One side is affected. Secondly, there is in psoriasis, you get more hyperkeratosis. You get a fissuring. While in tinea, you hardly get fissuring, you get superficial scale comparatively, including the border. See, this is another patient. This slide that I picked up from Dr. Ravi Vadrevu from Kakinada, where I'm associated with him since 94. And every year I go to see patient of HIV. Of course, but whenever there is any dermatological interesting cases, we look. So this is the patient he showed me. I said it can be atopic, it can be contact dermatitis, or he was a farmer. It can be because of the farming. Then he said, now see the next slide. Say that this is the thing it has called aspergillus nidulans. So, you know, we do not know unless until any chronic disease, if you go for what is the cause, so you have to take help of lab, pathology, microbiology, everything. Now, only just clinical science are not enough for the final diagnosis. Then palmoplantar psoriasis, you have to differentiate from atopic dermatitis. Many times patient comes to my clinic and I'm just telling the real story. If you have passed from Grand Medical College with the old teacher, you will think of atopic. You have passed from other medical college, they think of psoriasis. But more common is atopic, not psoriasis. There is more likely atopic, and that history will help you. And of course, the biopsy. Pustular psoriasis, you have to differentiate from the pompolix, but pompolix, they are not a lake-like or like a group. They are not like that. And history of atopy will get it. So this is how the differential diagnosis was very important. That's why I give more stress. Now, when a patient of psoriasis comes to our clinic, at least what I am talking about, 12 years back when I got involved in the clinical trial, secukinumab international trial was done in my clinic. That time I was interested. One of the wing in my clinic was clinical trial. Of course, we have got a cosmetic, we have got a hair transplant, clinical dermatology and HIV. We have got 4 or 5 wings, but clinical trial was the 2 doctors who were only doing the clinical trial. So that time I learned when you are managing patient of psoriasis, you have to assist them. Just going for, just patient is coming, just seeing the extension of lesion is not enough. So what is called psoriasis area and severity index is a PASI. Physical global assessment, that is the physician's global assessment, and quality of life measurement. These are very important in practice if you want to really, you are concerned about the patient. So when you're talking about this area is this figures, everybody should have this figure if you do not remember, but it's very easy to remember 9% and 18%. Then coming out when they talk of severity, either erythema, thickness, and scaling. These are the three parameters they look for: grade 1, grade 2, 3. So this is one of the patients. I just giving the example. He came to our clinic. Of course, these are erythematous extensive lesions. We started this patient on adalimumab. Then see, after 2 weeks, erythema disappear and scaling disappear. Then, then again on the second visit, see, almost it become flat. Then third visit, there is hardly anything except pigmentation. Though this, of course, this was because of the adalimumab, and this is of course completing adalimumab course. There are hardly anything, even the pigmentation is also traced. So what I was talking about, how to keep this PASI score. PASI score, there is an app, you have to download app. If you download app, it's very easy. For example, if you see this patient PASI score initially was 27. That is on the 5th of October. But after 15 days, that is second week, that is 20th of October, PASI score became 25. Like that in the third visit and the fourth visit, I showed that hardly anything. PASI score is 6.4, only pigmentation. So this is how we can maintain, and if you give this, it impresses patients also more than we know what we are doing. Then that's why the PASI score, if you can get that app down, try to keep in your clinic and to utilize. But there is another survey. According to that survey, PASI score is in clinical practice is difficult. So what is they call is a physician's global assessment, where they say physician global assessment advantage are there, is easy to do it, it's quite sensitive, and the doctors are comfortable. So if you are comfortable, you can go for physician's global attachment. Similarly, you can do the nail. Similarly, you can do for the scalp. Similarly, you can do the palm. But now the third parameter, third assessment is the quality of life questionnaires. Quality of life questionnaires help you the severity, how the patients have their physical, mental, or social impact on his life. That is very important. So these are the things, whatever you want to go PASI score, physician global assessment, and of course, the questionnaire is, after using questionnaire, you realize questionnaires are not necessary because we know how to take the judgment of the patients. But now you have gone more than what is called is a skin manifestation, that is called integrated approach. The meaning of integrated approach is thinking of the comorbidity. One of the comorbidity, of course, common is psoriatic arthritis, and as I mentioned, cardiac problem, liver problem, kidney problem. So many internal systems are involved. So according to this, one of the American study, they said the application of, the benefit of integrated approach of psoriatic patient with the health and quality of life, but it will also optimize available resources. So, so now our next approach in psoriasis is integrating the comorbidity along with the skin. So these are the problems. Sometimes there's psoriatic arthritis. So any patient of psoriasis come to your clinic, you have to find out, because the earliest treatment if you give to psoriatic arthritis, the results are very good. You can prevent what you call the sequelae of psoriatic arthritis, continuous pain, disability, you can prevent. So earliest detection, always ask those patients whether your joints becomes tough, they are rigid, do you get a pain during night time? These are the very simple question you should ask every time patient comes to. Then obesity, of course, obesity from the waist circumference, or you can make out, you can go for the waist circumference, male and the female. Usually the women is more than 88 and the male is more than 102. Hypertension, so any patient of psoriasis come, I would like to mention, I was not aware of this hypertension When I started 12 years before about the clinical trial, blood pressure was must in clinical trial. So otherwise we hardly wish to take blood pressure. And then we realized 60% of psoriatic patients, they had hypertension. Psoriasis patient, hypertension. So any patient of psoriasis come, you must have a baseline blood pressure and you have to measure it. Dyslipidemia, this is another comorbidity patient they get. So any patient of psoriasis come to clinic, there are basic tests. One of them is lipid profile. Then of course the liver, non-alcoholic fatty, that is called NASH, that is non-alcoholic fatty liver disease. That is also is one of the comorbidity. There are many metabolic, diabetes, underlying lymphoma, anxiety, depression, many. And most important is the cardiac comorbidity, cardiovascular risk. As we know that there are risk, many hypertension, diabetes, smoking, alcohol, many factors are, but because are there what is called inflammatory cytokines, which may aggravate atherosclerosis, and there are chances of cardiovascular disease, including myocardial infarction, stroke, and even death. So we have to keep in mind of psoriasis. So we know now what are the problem of psoriasis, how to diagnose, what are the differential diagnoses, and take care of comorbidity or integrate comorbidity in your practice. Of course, it's a team practice, so you refer to the respective faculty. There is diabetes, take help of the diabetologist. The cardiac problem, take help of the cardiologist. But then, what are the problem of managing psoriasis? According to assessment of psoriasis and psoriatic arthritic survey, if you see here, almost 40% of the patient, they don't take treatment of psoriasis. They do not approach. Almost 50% of the patients, they take only topical treatment. And very few patients, they take systemic. See, maximum 14%, but even 2%. So there is hardly utilization for systemic therapy. That's why this survey has given identified unmet needs warrant additional attention, action, including improved severity assessment, psoriatic arthritis screening, and treatment options. So we have got many more things to do, not just confined to the skin. Again, this is the same thing. So important, now we know that we have to assess properly, take care of comorbidity, but what should be our goal? So when you are thinking of the goal, what is the patient goals, your goals, and you have to find out midway. Because patient expectations are high, but there are limitations, and the cost in our country, the cost is a problem. So you should have joint consultation, you and the patient. For example, what they found, the care, psoriasis care increases if educate patient. For example, explain to the patient, patient becomes well educated about psoriasis. When it becomes well educated, is enhanced patient satisfaction. And if you see here, almost 68% of the patient, they would like to take decision discussing with you. Of course, 28% they'll say, doctor, whatever you say, and 7% they'll take their own decision. So if you take patient and your discussion together decision, that will have better care. That happens in any chronic disease, whether it's a psoriasis, whether it's HIV, whether it's a diabetes or anything. For appropriate treatment, now you must have realized that disease severity, comorbidity, and psychological factors. In the comorbidity, I mentioned many times. So when you are having the goal PASI score is very important. For example, your treatment give PASI score less than 50. That means the treatment is not effective. You have to modify treatment. If the PASI score is more than 50 but less than 70, But dermatology life quality index is more than 5, you have to modify. Less than 5, you can continue the regime. Or partial score is more than 75, you can continue. So you can addition dose, you can add some topical treatment, you can add any systemic that I'm going to cover next. So now coming to the treatment, we have seen the treatment for Gokerman up to now what is called PDE inhibitor apremilast, biological. So there a lot of development has taken place. So when you're talking of the treatment is very simple things that initially limited lesions are there with your topical treatment, then give phototherapy, and then you give systemic therapy, either is retinol, methotrexate, cyclosporine, biological, or acetretin. So it depends upon the severity of the disease. Moderate to severe disease, you have to go for systemic treatment. So these are the topical agents. Most of us, we know topical agents, so I'm not going to discuss because we know about the poor therapy also. Many doctors, they are practicing poor therapy. Poor therapy is ultraviolet A, ultraviolet B, narrow therapy, and the broadband therapy. Poor A narrow therapy is well accepted, but when you are giving this, there are limitations like some people get nausea, depression, phototoxicity, and in long term you have to think of what is called in the theory they have given the cancer, but at least I do not know anybody has developed cancer or any reported case in our country. Then coming to systemic therapy, when to use systemic therapy? Of course, when you say the BSA index is less than 10%, moderate and severe always we can select systemic therapy, but even even the BSA is more and the quality of life index is less than 5, I think you have to think of systemic therapy. For example, somebody comes to the involvement of only nails, but that is disturbing. The social impact is so high. The patient needs some treatment, some cure. So where you can go for the systemic treatment. So there is no hard and fast rule that hard and fast rule that it has to be index as to high. It depends upon all three: severity of the index, social impact, and the comorbidity. So again, this is the repetition of same thing. So which drug should be used? Methotrexate, acetylcyclosporine, apremilast. I'm going to cover this. This is the guideline is according to American Academy, European, when to use cyclosporine. Cyclosporine is one of the good drug you can use in the induction therapy, intermittent therapy, or the maintenance therapy. Yeah. So most of us, we are using methotrexate. According to me, methotrexate is considered one of the gold standard, but it has got limitation. Apart from the side effects, its efficacy is that not good. So methotrexate I use in my practice for the maintenance, not for the initial treatment. Unless until patient is not affording, we can use methotrexate. Cyclosporine, according to me, is a wonderful drug. If you use properly, is very effective drug. In fact, it accelerates what we call is the subsiding of psoriasis or the healing things accelerate. So some people use what is called quick therapy of cyclosporine. Acetretin. Acetretin is another good drug, but when you are using acetretin, elderly patient, dyslipidemia, liver disease, you have to be very careful. Poor therapy, we mentioned about this. So usually when to consider the systemic, the body surface area more than 10%, but significant body surface area even less than 5%, but there is more affection of the quality of life, you can use it. Systemic therapy. When you're using systemic therapy is something called rotation therapy, because if the same drug we give you long time, it will have its side effects. So for that purpose, you can rotate therapy. You can start with methotrexate, then you can go for a poor therapy, then cyclosporine, acetretin, and again poor therapy. or immunomodulation. He can keep in the rotating. Rotation is not recommended in biologicals because they develop, if you discontinue biological, they develop antibodies or their potency goes down except etanercept. Then sequential therapy, like a sequential therapy, initially you can use biologicals to bring down the disease under control. Then switch it to less effective like cyclosporine. Then you can methotrexate. And ultimately on apremilast, I'm going to cover in some patients. But when you're treating the patients, there are certain challenges that this is the one of the finding from the National Psoriasis Foundation survey, that no treatment or under treatment of the patient with psoriasis remain significant problem. I showed you one of the graph that almost 50% of the patient, they take only topical, even they need systemic, or 40%, those are almost 90% of the patient, they take under treatment. So this is a big problem. The same thing is if, and 52.3% of patients, they are not satisfied with the treatment. So these are the challenges we are going to. In severe psoriasis, again, same thing. Topical therapy, most of the patients, they require systemic therapy, but they go for topical therapy. So these are the problem. The challenge in treatment psoriasis, again, systemic therapy are underutilized. Just now mentioned that. And there is hardly any sensitization of systemic therapy. The next problem with the patient is adherence of treatment is very poor. If you see 30% of the, all patients of psoriasis are not adherent to their, see why adherence is very important. I learned from HIV, because any chronic disease, psoriasis is a chronic disease. The success of managing chronic disease is in adherence and compliance. If you do not follow adherence and the compliance, I'm not sure whether I'll be able to treat patients, satisfy patients, or able to prevent their sequelae. So adherence and the compliance plays major roles in any systemic disease, any chronic disease like psoriasis. The under treatment of psoriasis, I said that there are a significant number of patients that are undertreated. So we know these are the problems like a poor adherence, there is no treatment, there is a dissatisfaction among the patient with psoriasis. There are more number of patients, even they need systemic therapy, they take only local or topical therapy. So now we are discussing the role of systemic drug like acitretin, methotrexate, cyclosporine, all we have discussed, and poor therapy. But now we have now talking of the biological in management of psoriasis. See, in the management of biological psoriasis, first we know what are the biologicals. Biologicals are, there are of different action, that is anti-TNF alpha like infliximab, adalimumab, golimumab, there are many. Anti-CD4 like rituximab, you have to read it. If you read it, you will remember. If you use it, definitely you will remember. So they are US FDA approved for many conditions. Rheumatoid arthritis, hidradenitis suppurativa. There are many conditions, Crohn's disease, ulcerative colitis. There are many conditions where the biologicals have been approved in US FDA. In our dermatology, we use for pemphigus, psoriasis, hidradenitis, chronic urticaria, and there are many more conditions. Those are the offline indication. So biological in psoriasis, usually the T cell activation, you know that T cell activation is required for psoriasis, so you can block it by blocking interleukin 23, interleukin 17, or TNF alpha antagonists like adalimumab, infliximab, or etanercept. So when you're talking of the biological, there are upstream and the downstream. Usually downstream are blocking interleukin 23 or interleukin 17. Upstream CD6, that is itolizumab is there, So there are very like secukinumab. I did an international trial of secukinumab in this 2012, and this drug is very effective. Patients were very happy. We were also very happy about this. But there are many, like TNF alpha, etanercept, infliximab, adalimumab, triggering 20 interleukin 2, the ustekinumab and secukinumab. There are many varieties are available. Of course, now PDE that is separate. So when to use biologicals? As it says that biological depends upon the severity index, the psychological or what you call social impact on the patients, and of course affordability. Affordability is very important. So if the BSH is more than 20%, you can give. BSH is more than 10%, but there are thick plaques, you can use plaque psoriasis. So whenever the patient severity is more, patient is disturbed, under depression, even severity is less, you can start using it. And we know conventional treatment has got a lot of limitations of their efficacy, their long-term treatment. Even they are inexpensive, their side effect and efficacy is limited. That's why there is a need for what we call is a biologicals. Most moderate and severe, what are the challenges of biologicals? If you see again, 30s, this biological use of biological almost, if you think the percentage of patient, doctors are using biological is very less. Most of them are either topical or no treatment, but biological is very rare, 1%. Then there's biological therapy, vice versa. If you switch from the conventional therapy to biologicals, the biological to classic or what is called systemic, and for classics to biologicals, very less. Number is less because there is no sensitization or there is no proper this thing. Then now coming to, we are going to today talk about mostly adalimumab. But here we are consider campaign study and restore study where they say PASI score. PASI score is 75 and 100 they are compared. They are compared with the methotrexate and adalimumab. Adalimumab and methotrexate. If you see the blue is methotrexate. So methotrexate only 7.3% can achieve 100%, only 18% can achieve 75, while adalimumab can achieve almost 80%, which is the goal or which is the expectation from the patient. See, this is one of the study compared with the all, whether if you see, I'm talking about adalimumab, the reason being that is the only cost-effective drugs is available in our country. So almost is comparable to ustekinumab or infliximab. Is hardly there is any change. Of course, the campaign study I showed you, they compared with the methotrexate. And if you see the comparison, the methotrexate, the adalimumab compared to methotrexate and placebo is far, far effective. This is another study where PASI 75, yeah, comparatively what you'll find at the end of 60 weeks, we can achieve 71% if we use adalimumab. Even compared to secukinumab, adalimumab is quite comparable. Only thing is slightly delayed. Then coming to given the route of administration, infliximab is definitely more effective. It brings down the disease under control very quickly compared to adalimumab. But you have to give IV. When you have to give IV, I don't think patients also are not happy and the doctors are also not happy. So they prefer subcutaneous. That's why adalimumab is preferred. Then coming to is assessment the response. Infliximab take 14 weeks, while adalimumab 16 weeks. The difference of only 2 weeks, but there are other advantages of adalimumab, and that's why we prefer adalimumab. Then compared to alifacept, ustekinumab, etanercept, infliximab, adalimumab. If you see the malignancy, there are chances of malignancy. If there is underlying malignancy, there is proliferation of malignancy. While in adalimumab, there are chances of reactivation of tuberculosis, but chances of malignancy is very less. But tuberculosis is manageable. In HIV, we manage, so this you can manage very easily. Again, if you go for the response, efficacy, infliximab gives a maximum efficacy, 80%, while adalimumab get 80%, but it takes a longer period. So adalimumab is comparable. Then older biological compared to adalimumab is better. So the suggested treatment goal, initially it was 75%, then came to 90%, and now they said, why not to go for 100%, more than 90%, PASI score 100%, that is the goal. So achieve these goals, what we need very effective drugs. In fact, now everything is changed. That day I was listening to rheumatology, my HIV experience, or any chronic disease. Remember, the strategy is to hit hard and early. So hit hard and early, we need what is called biological, because they are the things will bring down the disease under control. Once the disease comes under control, you can switch your to on the maintenance, and after maintenance, the prevention. I'll show you in my patient. This is the guideline is given for American dermatology that adalimumab can be used very safely and is very effective. So we'll go for the real practical experience. Pratik, just remind me if I'm crossing my time, but I would like to show them the patient.
No worries.
This is very important.
We have time.
See, this is one of the patient. He came to our clinic with the edema of the face, exfoliations or peeling of the skin, dry skin, and he dry skin. So we thought probably we are dealing with a psoriasis, but from history, he was diagnosed as a pemphigus vulgaris, and he was on a Zempred for last 10 years. He was taking Zempred for last 10 years. From 2008, he came in 2018 to our. I was a little bit doubtful whether it's because you have to find out. I'm not doubting the person, doctor who was treating, but better to confirm because he is taking systemic steroid for 10 years, so we have to find out. So we repeat a biopsy and see what a biopsy came. Biopsy came psoriasis. So he diagnosed as a psoriasis. We do not know about his past history. I asked for the biopsy of the past. He said, doctor said, no, aap fikir mat karo. A pemphigus hai. And he was being treated with a steroid for that. We did this. Then what we did, we start, because of he is on steroid for long term, we started with the involvement of the face, cyclosporin 100 milligram OD and tapering Zempred. Then we made 50 milligram, and then in 2018, we started on 30 milligram of apremilast and see the result. So cyclosporin, what we call steroid sparing agent, we should utilize also. This is an example of the patient who did very well, and he is on apremilast. He did not get any recurrence. He came to us in 2018. He comes for follow-up. Now he comes every 3 to 4 months. He is on apremilast. This is so that was the what we call the psoriasis, how to treat with steroid sparing agent. This is the combination therapy. For instance, this patient was unable to afford BID doses of cyclosporin. We started with methotrexate this patient with 100 milligram cyclosporin. So you can combine methotrexate and cyclosporin. You have to only careful about the kidney function you have to monitor. And currently he is only, we gave for 6 months, and currently he is only on the emollient. So you can and see. So this patient was given methotrexate and cyclosporine. So this is an example of combination therapy. This is another 34-year-old male patient, psoriatic erythroderma. See, he has got erythroderma. He came from Aurangabad. He was on long-term steroids, and he had taken other drugs. With the methotrexate, he developed thrombocytopenia. See, such a extensive, he came with complete this. So now I don't have to tell what drug you have to use. Of course, we started using this patient on adalimumab. First, we give 6 injections, then after 6 months, cyclosporin was introduced 100 milligram BID. Then after 6 months, everything completely resolved. Then we started apremilast and low dose of cyclosporin. Then again, but the patient had some recurrence slight. We again added adalimumab for 3 months. Then after that, we gave cyclosporin 50 milligram. And see this patient is on 50 milligram cyclosporin, and everything is gone. See, everything is under control. So this is the combination therapy. This is another patient, we are given only cyclosporin for 3 months, and patient is. Yeah, this is very important. There are offline indications, like this patient had lichen planus. He was in a hurry. So we started this patient on adalimumab. When he started on adalimumab, he came with lymph nodes. When he came with the lymph node swelling, you know what is it? It's very common. In our country, TB is endemic. So before starting any biologicals, you must rule out, I'm going to tell you what are the investigation you should do, but you must rule out underlying tuberculosis. That is must in our country. Of course, you should look for a history of malignancy also or infection also. So this patient developed lymph nodes. When he said they did FNAC and they found what is called is a epithelial granuloma. Of course, I am being HIV clinician, I know how to treat TB and patient become all right. So any patient develop TB, do not get scared. TB can be treated. This is another patient we started treating, started with a cyclosporin for 2 weeks and there was no response. What he'll do? Because lesions are expensive, patients are psychological impact, you can go for the higher, like I will go for the biologicals. Then combination therapy. So now you have seen steroid sparing agents, you have seen combination therapy. Now I'll give an example of rotation therapy. This is a 60-year-old male patient came with the extensive psoriatic plaque in 2013 and still is following it was. Started with cyclosporin, Again, this 100 milligram continued till August 2014, stopped in September because everything was okay. But again he came, because the cause, again we started in December 15, develop hypertension. When he developed hypertension, our dose was 100 milligram, we made it 50 milligram and we added methotrexate. He was doing well up after cyclosporin, again there was exacerbation. So we added acitretin to cyclosporin. We added acitretin to cyclosporin, 50 milligram, acitretin to, but he developed dyslipidemia. Then of course, because he could not afford biological, but we started Visolon 20 milligram. And if you see today, that he is only on apremilast. We are following in 2013. How many years? Almost 7 years. So we can manage patient, but you have to keep long-term management. See this patient before and after. So the message here that we must learn to manage psoriasis as a chronic disease, long-term management, start initially with hit hard or intensive therapy. Either if the patient can afford, explain the patient what are the advantages of the hard therapy, biologicals, not biological, then cyclosporine, not or systemic therapy, and then go on maintenance therapy and then prevention therapy. This is how we should get it. This is the another patient. There are many patients that we are treating. So, of course, another indication, there are many indications. One of the patient we treated with the hidradenitis suppurativa. See, this is the patient, he came with multiple ulcerative nodular lesions in the both axially. We did a biopsy, it turned out to be hidradenitis suppurativa. We started with adalimumab biopsy after first injections, after first injection other side, and the patient. So before using any biologicals, see CBC, LFT, checks, X-ray, the gold or Montu test. We use Montu test if the patient is not affording. It's very PSA because the patient is the elderly patient. Mammogram, pap smear. Ideally, you have to rule out the underlying malignancy. And you want to do vaccine. The live vaccine cannot be given. And surgery, usually the patients prior to surgery, you have to stop this treatment. So these are the precautions you have to take it before starting biologicals. Of course, TB, of course, and you have to underline, of course, you have to look pregnancy, lactation, underlying hepatitis B, hepatitis C, and HIV, and what is called unmasking of TB or untreated TB or occult TB. We have to rule out that. There are many studies, they said, but at least I can tell you if they develop TB, we can treat very easily. We can treat like a patient of HIV comes with 40, 50 CD4 counts. They develop TB, we can treat. So don't worry about the TB. So in investigations, I think once you start this therapy, you must mention this, maintain this. In pediatric, adalimumab can be used pediatric after force less than 18 years. But what is important in pediatric, the dose is 0.8 milligram per kg. That is very important. Now, when we are talking of the biologicals, but we have come that the latest thing, what we call is a JAK inhibitors. Now we are dealing with the JAK inhibitors for psoriasis, for atopic dermatitis, or for any inflammatory like pustulosis, polyhydramnios, psoriasis. Many conditions now the JAK inhibitors are available. That is the latest treatment. And before I closing, I would like to say that psoriasis is a systemic disease. You should treat for the chronic, long-term management, hit hard with the powerful or the most potent therapy, maintain it, and then prevent it. If you do it, complications of pro-inflammatory cytokines produced by psoriasis in their future, or we can prevent all this sequelae. So thank you very much. And now we'll open for the questions.
Yeah. So request doctors, doctors is waiting for your any doubts that you wanted to share. You can unmute and speak, please.
Yeah, please repeat the question. Huh? Whoever asked the question. Yeah. Okay.
Yeah. Yeah. Anybody having query or question on this treatment of psoriasis?
So there are Cadila, share your chat box.
I think you need to unmute. Nirmalya, can you unmute?
Yeah. One of the question is there from Dr. Raju. PASI score is below 10%. Can we go for biological? Yeah, you must have realized that when any patient comes to your clinic, clinical severity you have to take in the account. the what is called is a social impact or psychological impact. So even the clinically the score is less than 10 or below 10, the patient psychological impact is high. What is called dermatology life quality index is very low, then you can use it. In fact, like they come with, I mentioned that involvement of only dorsum of the hand, they are dealing with daily. So every day they get reminder from somebody in life, and that disturbs them so much. And if you can use biological, definitely that will lessen the burden on patient, and patient will definitely live better quality life. So we can use it. Yeah,
Thank you, doctor. Thank you very much.
yeah.
Yeah.
What
Any other question?
is of
Yeah, doctor, your voice is not
what
audible.
the dosage of
Yeah. No, dosage,
the dosage of methotrexate?
yeah, yeah. You asked very good question. Usually we use 7.5 milligram per week, but where I'm attached, there are oncologists, there are rheumatologists. Rheumatologists say start with the 15 milligram minimum. We as a dermatologist start with 7.5 milligram. And the oncologist, they start directly with the 80 milligram. So it depends upon the confidence you develop the practicing. But I will suggest initially better to start with 7.5 milligram, because sometimes there is idiosyncrasy, and I have seen two patients going into septicemia, and it's very difficult to treat them. So better to start with 7.5 milligram. Initially, there is no idiosyncrasy. Then you can raise to 15 milligram. And the latest approach toward the methotrexate, that nothing like 1.5 gram or 2 gram. They said you can give for 5 years, 10 years. What is important is monitor liver function test. If they are normal, you can go ahead with the methotrexate for long. Very good question. Yeah.
Thank you, sir. Thank you.
Any doctors?
भैया भैया भैया
Yeah, Dr. Abhignan Sai.
Yeah, Dr. Sai, what is the question?
I think.
No.
So if any,
Yeah.
if you are not having any questions, we can go ahead for the winding up this session.
Yeah, because it has become lengthy, ne?
Yeah. No. It was actually wonderful.
Okay.
It was a wonderful session, actually, the comparison. And I think many doctors those we have invited still under the practice. But as far as today's sharing and knowledge by you is doctor is wonderful. I've been watching and seeing these all CMEs. The comparison which you have made is all international standards. So that has made most of the doctors who are presented and understood that the clarity and the your way of approach. I think hope everyone is enlightened. Thank you very much, Dr. D G Saple. Today, out of all busy, you being an international speaker coming into this webinar and making this the sharing the knowledge of adalimumab biosimilars treatment along with other therapies, so that you have clearly, completely given an understanding the each and every medical fraternity and the rest of the people. That's a wonderful day today. And you being a speaker, we are really honored, and we really thank you. And today is a wonderful day. So have a wonderful day. And I thank all the participants, those who have come and enrich the knowledge with Dr. DG Saple. And I thank you, our Vice President, Mr. Amit Ajmera, and our President, Mr. Uppi Singh, for giving an opportunity conducting this kind of a program. And I also thank you, Dr. Pratik, coordinating with the Dr. DG Saple for all the informations and relevant to the subject relevant to the knowledge. And I thank you all my team members, marketing manager, Mr. Deepak, and sales head, Mr. DP, and DP Singh and other sales managers. Thank you very much for supporting for this. Thank you very much.
One second. It's a request for everybody because always we have to learn from each other. So any dermatologist, we have got any suggestion, please inform to the Cadila. They will inform me. I'll be very happy because always we learn from each other.
Yeah,
So
doctor,
please
we have
don't
made a group.
hesitate to inform. Yeah.
We made a group, so you are also there in the group, and they can ask the questions and queries that you can enlighten them.
Yeah, right. Okay.
Thank you.
Thank you. Thank you,
Thank you very
everybody.
much, doctor. Thank you very much, all. Yeah. Thank you. Thanks a lot.
तो वो हाँ मैं समझ गया